Hello, everyone. My presentation is on sleep disturbances and post-traumatic stress disorder. Post-traumatic stress disorder can be defined as a mental health condition triggered by experiencing or witnessing a terrifying event. Symptoms may include flashbacks, severe anxiety, uncontrollable thoughts about the event, and as this presentation will focus on, sleep disturbance such as nightmares and insomnia. According to the DSM-5, sleep disturbances caused by PTSD can be characterized as the re-experiencing of traumatic events in the forms of nightmares and difficulty in initiating and maintaining sleep. Often, PTSD sleep disturbance can be grouped together as trauma-associated sleep disorder. However, not everyone with PTSD has this disorder. PTSD has been found to be associated with a heightened amygdala responsivity during symptomatic states and during the process of trauma-unrelated affective information, a volumetrically smaller and less responsive medial prefrontal cortex, and a hippocampus with diminished volume and integrity. Sleep disturbance caused by PTSD has historically been hypothesized to be associated with altered REM and NREM sleep. First proposed in 1989, PTSD is associated with heightened REM and altered REM sleep. Heightened REM sleep is associated with overreactive amygdala responsivity found in PTSD patients and is known to facilitate sleep disturbance. Literature on this component of sleep with PTSD links it to two manifestations of sleep disturbances: insomnia and nightmares. Insomnia is associated with altered NREM sleep and is characterized by difficulty falling or staying in sleep. Insomnia and PTSD is thought to arise due to NREM sleep disruption caused by the disorder. Other parasomnias associated with NREM sleep include nocturnal panic attacks and sleep terrors. Altered REM sleep is associated with nightmares, characterized as repetitive and distressing dreams which contents relate to the traumatic events experienced by the patient. Heightened REM sleep is associated and caused with an overreactive amygdala and dampened prefrontal areas caused by the disorder. Post-traumatic nightmares differ from nightmares experienced by those without the disorder due to its content. While normal nightmares' content is typically random and without a known cause, post-traumatic nightmares are typically thematically or semantically related to the patient's traumatic experiences. This can be experienced in a spectrum of ways. However, there are four main types of nightmares associated with PTSD. Firstly, replicative post-traumatic nightmares, in which the dream is a replication of the original traumatic event. Secondly, non-replicative post-traumatic nightmares, in which dream content can be trauma-related but not a replay of the traumatic event. Thirdly, post-traumatic nightmares, which are frightening post-traumatic dreams that awaken the sleeper. And fourthly, post-traumatic dreams, in which dream content is associated with the previous trauma. There have also been several treatments used to help alleviate sleep disturbance in PTSD. However, there are no standardized intervention protocols. There are two main categories by which sleep disturbance and PTSD are targeted. Firstly, behavioral therapy and intervention, and secondly, pharmacological intervention. This is a very rich area of research, the scope of which I do not have enough time to fully delve into in this presentation. In treating sleep, cognitive behavioral as well as other types of behavioral therapy is often preferred. This approach uses targeted interventions to modify specific behaviors associated with sleep disturbance over an extended period of time. In treating sleep, cognitive behavioral therapy uses multimodal interventions such as sleep restriction, stimulus control, relaxation training, cognitive therapy, and sleep hygiene education. These interventions are particularly helpful for treating insomnia. Other behavioral therapies used to treat sleep disturbance in PTSD, particularly for managing nightmares, include imagery rehearsal therapy, exposure prescription therapy, eye movement desensitization and reprocessing, and lucid dreaming therapy. Another common method in treating sleep disturbances in PTSD is through pharmacological interventions and therapy. Melatonin and benzodiazepines for insomnia, and symptothyroidic medication and antipsychotics and antidepressants for nightmares are all potential pharmacological prescriptions that have been used in aim of treating sleep disturbance in PTSD. However, the evidence of pharmacological effectiveness of sleep disturbances in PTSD is limited and typically not preferred. Sleep disturbance caused by PTSD can also affect psychological functioning in waking life. Chronic nightmares and PTSD, for instance, have been associated with adverse consequences and decreased psychological and physiological functioning. This also works as a feedback cycle, further facilitating disrupted and disturbed sleep in PTSD patients. Insomnia has also been found to negatively impact waking life, also heavily associated with disrupted waking psychological and physiological functioning, as well as many other medical and psychiatric disorders such as depression and anxiety. In conclusion, Sleep disturbance is a costly and salient symptom experienced by those with post-traumatic stress disorder. There are many treatments used, however, further study would benefit in focusing on developing a more standardized treatment protocol for such disturbances. Thank you. These are my sources.